so glad that all of you made time to meet with us and hear some updates, and we'll have some time for open comment, but the agendas were posted earlier this morning on the website. I'll just walk through what we're planning for today. Just start off as we normally do with a welcome and some updates and then housekeeping items. We're gonna once again do some introductions of Medicaid staff. We will touch on some highlights of questions that have been answered on the August town hall meetings. And then AmeriGroup is here to discuss downcoding of claims and then open discussion. Kevin has been gracious enough to post the agenda in the chat if you want to reference that or use it to take notes. So officially welcome. Thank you so much for joining us. We're super happy for you to be here. Couple of things that we want to touch base on. We are starting to do some provider visits. I know that we have a few different integrated health home visits slated for the next month. But if you are interested in me or some of my staff coming out to visit, please do let us know. We'd be happy to. It might take a little bit of time to get scheduled, but we're always interested to see, you know, how providers are serving our members. And I know that you're all eager to brag about the great things that you do. So it's a great experience for all of us. We're also going to be doing some community integration town halls in October. The schedule isn't 100% locked down yet, but we will be getting that information out shortly. Kevin Kirkpatrick, do you know when we might be getting that schedule out?
Yeah, I think we're going to try for next week. We're just kind of finalizing some venues that we're reserving. So once we get those finalized, we'll share that schedule out next week.
The goal is to go to 4 different locations across the state and then do at minimum 1 virtual, possibly 2 virtual community integration town halls. All right. Let's see, we have had submitted our plan to spend our enhanced HCBS funding that we're getting through the American Rescue Plan. We've gotten conditional approval on that, which is great news. So we're going to start doing a lot of work to kick off some of those projects. We are working a lot on our strategic plan here at Medicaid. And just to give you a little bit of a preview, because it's going to feed into an area later on in the agenda, but we are working on doing some analysis of where we might have service gaps in the state. Obviously, we want to do everything we can to make sure that we're mitigating any type of service gaps for our Medicaid members. We're also working on really shifting a lot of our work and how we look at things more towards outcomes. And then the bucket we'll hit on a little bit more in just a minute is our efforts to update some Medicaid business practices. I know that we have heard from many of you that there's a bit of administrative burden on some of the things that are required. I will say that there is administrative burden on our side too, that we would love to lessen. And so really just updating some of the way in which we do business to make it more streamlined and efficient for all parties involved. And then third is, and this is why we're having the town halls, but increased transparency and communication. So creating more of a direct line to our Medicaid providers, our Medicaid enrollees, and other stakeholders to just give regular updates and an opportunity to speak about what some challenges might be in the community, and think about like really strategic things that we can do moving forward to really shift the program in meaningful ways. So once again, just a reminder, if you don't mind muting your line while you're not speaking, that's super, super helpful. I know the last time a lot of the questions and comments were put in chat. We can do that again if everyone feels like that works best, but also feel free to speak at any time that you might have questions, comments, things of that nature. All right, so we are going to be working on a project that is going to be impacting all of you, I know, in a positive way. So when I talked about updating some of the Medicaid business practices, we are working to, well, first of all, we got together with our Medicaid staff and really asked, hey, what do you think is the business process that would is most in need of some modernization and update? Where do you think providers are experiencing the most abrasion? And provider enrollment, credentialing, and screening definitely came back as a #1. Also on the member side, just being able to know for all of the provider community in the state, you know, which providers actually are taking Medicaid members. I know that that's a concern and a question that we get quite often, and we're not always able to answer that. So right now we are focusing on provider outcomes, and we've been working on refining some outcomes that we want to see in the future. They really do revolve around the outcome of spending less time, reducing administrative burden for the enrollment process for providers, making it a little bit more clear within our own Medicaid system what type of provider each of you are and what services you're providing, but also to streamline some of those processes as they come in from IME and then, you know, route to the MCO for credentialing. So if there's a way that we can do that in a more efficient way, that's what our goal is. Also with provider outcomes, it's going to be no surprise, claims payment and things of that nature are something that we're going to be working towards. Also, let's see, I think one thing that we're going to be doing very shortly between now and the next provider town hall is send out a survey to all of you that shows what all of the outcomes are that we're really going to start driving towards, and just get your input on whether or not you see those as valuable, and if we miss something, because we don't operate our best in a bubble. You guys are the ones that are doing the work, so it's important for us to get some feedback on that. Some of the language that we use here at Medicaid is a little jargony, and not everyone understands it. It kind of depends on what field you're in. So we're going to try to make it as simple and straightforward as possible.
Does that have
as well.
a dial on it?
So Kevin, Stephanie, is there anything that you want to add related to the provider survey and what we're working on?
Nothing from me.
All right, that's Stephanie Clark. She's one of our drivers of our systems modernization. So she's a very important member of our team. So that will be coming out. We're hoping that everyone participates. It's really a good opportunity for all of you to chime in on how we can make things better at Iowa Medicaid. So also, if you would be able to send in some information, you can put it in the chat, you can send it to the email address but what we're looking for are topics or areas in which you all might be interested in participating in work groups, and certainly provider outcomes could be one of those. I think another area certainly are things like prior authorizations, claims, and then, you know, other more salient issues as we move forward, like population health and maternal health and things like that. So if there are areas that you would be interested in participating, that would be great. Kevin Kirkpatrick did just put in the chat what our email address is that we're dedicating to this particular piece of work. And it is IME Town Hall, all one word, at dhs.state.ia.us. All right, so like last time, I did want to introduce some of our staff. They get up every day, they come to work, and they work really hard because they believe in the program. They advocate for all of you. They advocate for all of our Medicaid enrollees. And at the end of the day, our Medicaid program couldn't do anything that we do without them. So want to start off with Leann Moskowitz. Would you mind introducing yourself?
Sure. Hi, I'm Leann Moskowitz. I am part of the policy team at Iowa Medicaid. I manage HCBS waiver programs, the state plan, 1915I. I work with the health homes and transportation as well as employment support. So thanks everybody. It's great to be on the call and get to see many of your faces.
Thanks, Leann. Brian Wines.
Hi, I'm Brian Wines. I've got 27 years experience with the home and community-based waiver programs. For the past 12 years, I've been in the policy position and overseeing the intellectual disability waiver, the consumer choices option program, and the statewide transition plans. So those are my focus areas right now. Prior to that, I had 15 years doing the quality assurance and technical assistance with the HCBS program. And then 11 years prior to that, I was working in the field, working with providers in Iowa, Wisconsin, and Minnesota.
I heard that Wisconsin come through when you said Wisconsin. All right, Hannah.
Hi, I'm Hannah Olsen. I've been with Medicaid for 2 years in my current position for 1. I also work on a policy team, and my subject areas would be behavioral health and substance use disorder.
And Hannah also has been working hard for a long time on, we have an urgent member process here at Medicaid. Anytime that we have an individual who are having a hard time place or might be going through some type of crisis, Hannah works to get all of the information and really coordinate everyone. So she does a great job. Bob Schleder.
Hi, I'm Bob Schleder. I have been working with the Medicaid program for over 24 years now, and it's a real honor to work with some of the folks that are being introduced here tonight, because I mean the mission of the Medicaid agency, as somebody who is a lifelong Iowan, the mission is great. Even when it's really, really tough, you never feel like your effort isn't going somewhere worthwhile. So it's a great team to work with, and I really enjoy what we do here. I'm a business analyst with the Medicaid agency, and so the sort of outcomes-based certification Liz was talking to, that the provider survey that we will be putting out will start to speak to, is some of the work that I'm involved in. I also work with the high-tech program, which has health information technology, Some of you probably know there's a lot of money funneled through Medicaid and Medicare to support electronic health record infrastructure. Iowa had, through Medicaid alone over the course of the program, over $140 million invested through Medicaid in electronic health record infrastructure. And so we're looking to leverage that moving ahead through interoperability requirements and other things. Just a lot of work between the state level Medicaid and the federal government. Also work on things related to value-based purchasing as well as other things. It's a very exciting time at the agency. It's always full of change that is going on, and I know that can be frustrating sometimes, but from the standpoint of the work we're doing in this agency, I think you can rest assured that we've got a lot of very committed people, and it's a good team that we have here, and I really appreciate the feedback we get here and that we'll be getting on our provider outcome survey that we'll be sending in a little bit.
Thanks, Bob. Diane Williams, she keeps us all on track. She's our project manager. Diane, you on?
I am. I'm Diane Williams. I've been with Medicaid for just a little over a year. I came here from public health, and I was with public health for about 14 years. So my role is the project manager. So all of these projects that Liz is talking about, I help to support the staff and the leadership in completing those projects, keeping them on task, and making sure that we accomplish our goals. Maintain documentation, facilitate meetings, all of those types of things. So I'm the resident helper.
She does help a lot. All right, now we're moving on to 4 people. They manage really big contracts. One manages the Amera Group contract, one manages the Iowa Total Care contract, one manages the Delta Dental contract, and one manages the MCNA dental contract. So let's start off with Mary Tavija.
Hi, I'm Mary Tavija, and I'm currently managing the Iowa Total Care contract. I've been with Iowa Medicaid for over 25 years and worked in different capacities, but been managed care contracts since 2016.
Thanks, Mary. Becky Bloom.
Good afternoon, everybody. I'm Becky Bloom. I actually manage the Amera Group contract. I've been with Medicaid for 6 years now. And prior to that, I was with the Iowa Insurance Division. I did a lot of compliance reviews and all things health insurance.
Thanks, Becky. Heather Miller.
Hi, my name is Heather Miller. I've been with Medicaid for just under 4 years now. I'm with the Bureau of Managed Care. Up until just a couple weeks ago, I oversaw the dental program, which included Delta Dental and MCNA. But now I am transitioning to just overseeing the Delta Dental contract.
Thanks, Heather. Katie McBurney.
Yeah, hi there. Yeah, I'm Katie McBurney. I am newer to Medicaid, working alongside Heather Miller on the MCNA contract. I have experience as a dental hygienist Medicaid provider, also working with public health with the iSmile and iSmile Silver program and the Oral Health Bureau. So.
All right. Thank you, everyone. All right, so we have a number of provider Q&As from the last town hall, all posted on the website. Kevin put those in the chat earlier on, but we did pick out a few different questions just to highlight during this town hall. One is, we need to see faster turnaround time on providing quarterly addendums to the MCOs. We do have this conversation quite often, and I can assure you that we are working on trying to speed up this process as soon as we can. The delays are primarily due to the publication of the CMS Addendum B, unfortunately, which doesn't happen until a few days before the effective date. But once it does get published, we act on it as quickly as possible, but we have to take it and modify it for Medicaid coverage. and then we share it with the MCOs. We know that there is some opportunity to speed that process up, and we are working on it. Last year, there was discussion about recredentialing all the mid-level providers to be rendering providers and not just referring. Any updates on this? Physician assistants can now enroll as rendering providers. Providers should reach out to provider services enrollment department at 1-800-338-7909 option 2 if they are needing to enroll providers as such. And if you do have suggestions for other mid-level providers that should be enrolled as rendering, please send those our way. The next question is related to, will the Fqhcs get a raise in reimbursement as well? I think we had talked about some appropriation changes that had been made in the last legislative session that resulted in rate increases for a handful of provider types. Fqhcs weren't included in that, but we do have a pretty robust process of doing wraparound claims. At minimum, we have to always reconcile. Well, the MCOs have to pay the minimum provider specific PPS rate, and then we wrap to cost over at Iowa Medicaid. Has there been any more additional information given regarding behavior PPP edit regarding school-based Medicaid? In addition, will there be a focus on the school-based Medicaid provider manual regarding clearer requirements and billable services? You know, if there are areas where you think that more clarity is needed, we certainly will take those recommendations and run with them. We do want our provider manuals to be updated on a regular basis and pushed out. I know that we haven't always been completely on top of that, but that is one thing that we're prioritizing this year. We are continuing on this specific question, continuing to evaluate this area. We don't have a decision yet, but there will be one forthcoming pretty soon. Let's see, and just a reminder that schools cannot continue to use the physician code for their paraprofessional services, and continuing to do so does create a risk of audit and recoupment as the code being used does not match the service. But we're having discussions with billers about clearly defining the service being rendered and exploring options for alternate billing codes. So I think that's in Hannah's shop. She also covers some of those school-based services, I believe, and has been working really hard on that. So if you do have suggestions, please send them to that town hall mailbox, and we'll make sure to route them to her. I'd also like to know why the MCOs are allowed to require prior authorizations for items that IME doesn't require. Shouldn't they follow the same policy as Iowa Medicaid? This has been an ongoing question since we began managed care. I would say in principle, no. Managed care organizations aren't required to follow the same prior authorizations. Like Iowa Medicaid may have a PA process and Amera Group may decide it's not necessary. But what I do think we need to look at is being able to provide some additional information and rationale behind why those differences are there. So I know Becky and Mary were thinking about how they could put some of that information together and maybe bring back to a future town hall. So, all right. One of the other big areas of interest or question at the last town hall was related to downcoding. So Amera Group has come to the meeting and they just wanted to talk about that process, why they do it, and how they look at the process provider by provider, and do have an actual way in which they look at things, and then if it doesn't make sense any longer, they take those providers out of that downcoding process. So, AmeriGroup,
Thank you.
who's taking the ball on this one?
Yeah, yep, I've got it, Liz. Thank you, and good evening, everybody. My name is Jeffrey Jones, and I am the plan president for AmeriGroup Iowa here. And so, one quick comment before I turn to the leveling discussion here. I want to make sure I acknowledge the comments I see that are moving through the chat box here. We did provide, you'll note, Megan Lamoureux has provided her contact information out there. Please ensure you email her, because one of the things we will do when we leave these meetings, we will track on all inquiries that come in as a result and make sure we're monitoring those to closure to your satisfaction. So just want to make sure I put that reminder out there, and you'll see her information in the chat box as well. So I really appreciate the opportunity to maybe provide some additional clarity around E&M code leveling, specifically as it relates to our approach. And so hopefully I could clear up a couple of key components of this here, and everybody has a little bit of a better understanding. So first, starting with the why. And so why do we have the leveling in place? And so one of our responsibilities is ensuring that all claims that we receive are aligned with national industry coding standards, and specifically as it pertains to E&M codes, ensuring that they're being billed in alignment with AMA and CMS guidelines for E&M service code billing. And so with that, here's a couple of the key components here that really wanted to share with the group today. The first thing is that our approach does not impact every single level 4 or level 5 E&M claim. So our claims are actually very specifically chosen and identified for providers that are identified as statistically billing higher E&M levels on their claims when compared to their peers with similar risk-adjusted members. And so it is not every provider, it is not every claim that's a level 4 or level 5 E&M claim. It is specifically for those outliers that appear to be skewed when compared to their peers for the same risk-adjusted members. So that was the first clarification. The second component here is this process is under constant evaluation. And so what we monitor as there are disputes that are received, as additional clinical information is received, that continues to be monitored. And what happens is we actually remove providers proactively from this list once we see, okay, from a pattern, a billing pattern perspective, these services at this level are consistently appropriate based on the clinical information we're receiving now. We will remove providers from the list. That happens on a regular routine basis. And we just had a recent round of removals, in fact, actually. So you do have the ability to dispute when it occurs. You can provide additional clinical documentation to receive the higher E&M level that was originally billed. This is really, really critical that you do provide that clinical documentation that occurs, because that in turn informs our view on where are improvements we can make in the process, but more importantly, how we can see that, okay, we are seeing in this circumstance, based on the clinical being provided, consistently the percentage of overturns and reviews, really this individual should be removed from the list at this point in time actively. Yeah, I'll stop there, Liz, and see if maybe there's any questions, but really wanted to provide that additional clarity about our process and our approach here. Again, it is not for every provider. It is not for every level 4 and 5 E&M claim. And more specifically, there's an ongoing monitoring process to actively remove providers from the list that were originally identified so that they don't burden moving forward.
Jeff, there is a question from Sherry Hopper. What percentage does a provider have to reach before they fall off of this?
Oh, that's a good question, and one I probably should have been prepared for coming into this meeting today. I would, you know what, I'm going to take that one for follow-up, not because there's not an answer, but I want to make sure I answer it correctly. I don't want to give you a number and not be accurate here. So I will take that one as an action item takeaway that will get posted for everybody to review and understand. I apologize for not having it. And thank you for the question, Sherry.
I'm only using my phone to do math for my screens.
Does anybody else have questions on this particular topic?
Yeah, it looks like one just came in.
Oh.
How often do providers drop off the list? And so there is a quarterly and every 6-month review process that does occur. But I will also say that we also locally are proactively reviewing this list as well. So as we get feedback from a provider that feels they may be inadvertently burdened by this process here and the overturn rate's high from your perspective, we also kind of intervene and try to share that information and get those removed and pulled off of there as well.
Looks like there's one more question, Jeff, from Alex Matthiasen. They have 300 providers hitting the list, have been told the refresh will only happen every 6 months. Will that ever change?
Yeah, so the short answer is yes, I believe it will, but I do think it can get more frequent as we proceed forward. But Alex, what I would encourage you, again, Megan's email's in here. Alex, if you have a specific view and you feel like your providers are being inadvertently impacted by this, I'd love to hear that. So if you could send that to Megan, again, her email's in the chat box here, we can certainly follow up with that piece.
Hey, Jeff, it's Alex. I'm with the University of Iowa, and we have been talking to you guys in some separate meetings about this. So I've been talking with Robin Link specifically.
Yeah, and we do know, Alex, that a number of your providers were actually just removed or in the process of being removed. So we can follow up with that detail so you're aware of what that looks like.
Okay, thank you.
This is Steve Johnson from Broad Lawns Hospital. I just had one question. Jeff, is this what's known? We got one of our providers recently got a letter titled Risk Adjustment Provider Notification. Is that what this is? What you're describing?
No. This specifically would be pertaining to level 4, level 5 E&M.
Okay, so this is something different. With that, first time I'd seen it, it's Risk Adjustment Provider Notification.
Okay.
And you're using a contractor evidently to do some record review Episource. I just had not seen this before.
Yeah, and it's not jumping out right in front of me either, Steve. But if you want to shoot it over,
that's
to
fine.
me,
I mean, it's just we have a psychiatric urgent care, so I'm assuming, and that's where this therapist works. So she sees urgent psychiatric cases every day. So I'm assuming, but they're going to contact us. So I'll find out more when they call.
Okay, thanks, Steve.
Mm-hmm.
Looks like Kelly had a question. Does AmeriGroup deny based off of the statistics for E&M? Then providers have to provide their level is correct with copies of records. So what we follow, again, we're following national correct coding standards. We're following the AMA CPT code manual. And we're following the CMS guidelines for billing and E&M services. And so one of the key components of those guidelines, the appropriate level of service is based primarily on documented medical history, examination, and medical decision-making. Counseling, coordination of care, the nature of the presenting problem, and face-to-face time are obviously also considered contributing factors. And so really ensuring that the claim is coded correctly to reflect all of the services that are being rendered that justify the level 4 or 5 is really the critical component to make sure
Hey, Jeff, this is Kelly. I'm sorry, maybe you misunderstood my question. That's not what I was asking. I was asking, as you run the statistics on AmeriGroup, when a provider submits a claim, there's statistics behind the scenes. And what we've seen on our claims is AmeriGroup hasn't reviewed a single record yet, but they deny it due to down coding. And so my question is, are you denying it because a provider is behind the scenes on your statistic list and you're denying it based off of a record that you haven't seen yet? Then the provider sees that AmeriGroup has denied it and they have to supply medical records to support what the doctor has documented, that it meets all the requirements of the note that you just specified to get our money for seeing a Medicaid patient. That is my question.
Yeah, so I think the short answer is yes, Kelly. That's right. Again, and now if the claim has got the appropriate coding in it that justifies the level that has been billed based on AMA and CMS guidelines, then there would be no adjustment that occurs there. And so if there is an adjustment, that means is that when that claim is being adjudicated and reviewed, there is a lack of sufficient information in the claim that justifies the level it's been billed.
So are you basing that off of diagnosis code? What
So
is your
it's
trigger
based
to
off-
deny that?
So again, it's based on the coding combination that's been billed and based on the AMA and CMS guidelines. Are the codes that are being billed and the supporting information aligned with the level of E&M code that has been billed in that circumstance?
Yeah, and I apologize, maybe I'm not making myself clear. What you get is an E&M level and a diagnosis code. When the claim gets submitted to AmeriGroup, your system gets a date of service, who provided the information, a CPT code, and a diagnosis code. So what statistics are you using from the claim to say, we think this claim is incorrect coding, to deny it, thus forcing the provider to share the note to support the level? What data in the claim are you using to deny?
Yeah, so Kelly, I'm not prepared on this call to go to that level of granularity. We could certainly follow up there, but I think at the same time might be helpful, Kelly, if I understood what you used. And so, you know, there may be some information that could be learned there. So let's follow up on that piece. I apologize, I just don't have that level of detail on the fly.
We'll loop back with you, Kelly. All right, Jeff, I appreciate your time. Certainly as additional questions come through on this, just like we did with the last town hall, we'll send those over to you.
Thank you, everybody.
All right, so I am going to start at the top of the chat and start going through some questions, but if anyone wants to chime in, please feel free. I don't need to do all of the reading. If you want to unmute yourself, that would be totally great also. So obviously I can't answer some of these questions on the spot. So just like last time, we'll compile all of them and then get them routed and get some responses up on the website. But Walnut Creek Psychiatry said recently they received a letter from AmeriGroup about a review of diagnosis. Will you help us understand the purpose of this review? So I think AmeriGroup's going to have to follow up with you over at Walnut Creek Psychiatry directly. That I imagine that could be for a number of different reasons.
Have they reached out to their provider rep at AmeriGroup?
I don't know.
Yeah.
Well,
We're going to take it for action, Liz. Yep.
Thank you.
Okay.
We're not hearing you.
Liz, you're muted.
Thank you. There's a number of comments from Carroll Area Nursing. And so I need to go back up to the top. We've not received our recoupment back after billing correctly from AmeriGroup. When we have asked about it, we are told constantly it'll be looked into. We need definite answers. It's a lot of money. Regarding payment for the T100 or T1000, we billed the way we were directed and now it's denying for not a covered service. This too is being looked into, but never gets resolutions. We are also starting to have problems with additional authorizations after admitting patients. We are following the procedure and sending the extra paperwork, but the auths don't get approved. So Carroll Area Nursing, we will definitely be in touch. Thank you for putting all of your comments in there. Okay, how is the provider survey being sent to healthcare facilities? Will it be attention to someone specific within the organization? Hey, Kevin, I think that probably we're going to send the link out through an informational letter, but maybe you have an idea on that.
Yes, and we're asking for anonymous responses, so we're not necessarily targeting any provider group, any provider type. It's going to be sent through our normal communication channels, and those who want to fill it out can fill it out.
And everyone in your organization can fill it out. You can certainly make that business decision of whether or not you all want to have one unified response, or if you want to allow all of your employees to fill it out as well. I think all voices are important. Let's see, we have a comment, population health would be great. I agree with that. Bob is also a huge fan of population health, so we're very lucky to have him on the team. Other health insurance is a huge ongoing issue. IME sends files that the MCOs blindly load the unverified information. Many times these insurances have been termed long ago, or that what they show is actually a Medicare replacement plan. This is such a time-consuming process for all involved. It seems there could be a much better process which would result in a better outcome. Sherry, I agree with you. We have ongoing challenges with TPL and keeping those updated. So anybody from my team want to chime in? I'll just note that we have been working on this for a long time. We had issues when IME was the only claims payer or paid most of the claims. And of course, that issue does multiply when you pass files on to others. So we are working it. We have regular reconciliation processes with the MCOs on the TPL files that they are loading into their systems. So if you do have, Sherry, if you want to talk further about it, we'd be happy to reach out. Sue Gelling, good to see you, Sue. I have been trying to check on the enrollment status of 2 new providers with AmeriGroup. The contact phone number on the DHS website, 1-800-454-3730, and on my AmeriGroup provider manual to call for provider-specific questions routes me to member services. The people who finally answer the phone inform me they are not provider services and they cannot help me. It would be great if there was a contact number we could use to reach AmeriGroup provider enrollment that actually connects.
Yeah, that's an interesting one. Sue, thank you for sharing this. We have this one for action and takeaway. We will follow back up with you to make sure you've got that correct information. And then if our number is out of date on the DHS website, we'll make sure we get that update over as well, so it gets you to the right place the first time.
All right, Amber Sampson is asking, can you please confirm that the expanded telehealth services in effect statewide for at least 60 days after the public health emergency declaration is lifted refers to the federal PHE dates and not Iowa's PHE. It's not specific on the IME website. Bob, Amela, I'm almost 100% certain it's the federal PHE.
Yes, it's the federal PHE.
Okay, thank you, Bob.
We can make that more clear on the website too.
Thanks, Amber, for putting that out there. If you have the question, I'm sure others do too. Roger from Successful Living states, reviewing and increasing the habilitation rates after over a decade of no increase was a huge positive for providers. Can we expect future reviews and increases for habilitation services? That was a project that Leann, who you met earlier, put her heart and soul into. So we're really proud of all of the work that she put into that. What I will say on that specifically is we are working on developing processes to do basically regular annual reviews of all of our rates. Whether or not we increase those is a bit dependent on budgetary constraints that are a bit out of our control. However, we're going to continue to do those annual reviews so that we have that information available, so that if stakeholders are interested, we do have that available. And we can also see, as we're doing regular annual reviews of all of the rates across the Medicaid program, some rates go up and some rates go down. That's just how the program operates, especially on the pharmaceutical side and some of the physician administered drugs. So if there are areas in which some of our rates in the Medicaid program do end up going down, and we have a little bit of a buffer in our budget, we can apply those to rate increases potentially across other areas. So we're just looking at new ways to think about things, but we definitely do want to get fresh eyes on all of our rates every year. Okay, I think some of these are related to the down coding. Cindy from Avera has some questions about waiting approximately 2 years for payment on room and board claims, been told various times to resubmit with different information and now being denied for timely filing. What do we do about these claims that add up to over $60,000? Cindy, I'm gonna need to reach out to you, or if you can provide information in the chat about who you've been trying to bill, that would be great. Otherwise, we'll have your email to reach back out to you.
Yeah, it's a Mara group.
Okay.
And I did get a message from Megan, so I'll reach out to her. I mean, we've talked to several people over the past 2 years, and nobody can seem to help us. So hopefully Megan can.
All right, go Megan.
I just came in here trying to use the back.
I see Michael Martin, you have your hand up. Did you have something to say? Michael, if you do want to ask a question, you can now, or we can come back to you. All right. Byron Jarrett, we are not getting notified about these system errors and or the fixes, but we also have claims stacking up and or are being declined for timely filing, and this program is hurting many providers financially and causing them not to take Medicaid. Byron, that's definitely something that we want to avoid. We have to take Medicaid based on our location and our commitment to the urban inner city, but our staff have families and we would like to be paid for the work we do as well. Byron, what provider are you with? I think you got a mute problem. I'll be in touch, Byron, okay?
Well, Innovative Counseling Consulting Inc. I was typing it. And yeah, we're having problems right now with a little bit of both of the agencies, the MCOs, in regards to Total Care, as well as some from AmeriGroup. It's a bigger chunk right now from Total Care. If you guys check the records, you'll see every summer right around the end of June, they have a glitch in their system where things get backed up. And this has been happening since they came in. Now, right now, we've been waiting on a phone call or something back from them since May. We've had a couple of calls. We've gone up above our local area state rep to the Centene folks and all of that, it's still nothing. Then when we do get some things sent in as it comes through our biller, they try to pull the timely filing thing, but no, we've been working on this for a long time. So I'm a little fish in the pond. You see, I show up, I'm one of the small remaining providers of color here in the urban area, and especially in the population in which we serve. We serve that high risk, at-risk population. We're not afraid to go help nobody anywhere. But if we doing the work, but y'all not getting us reimbursed and I can't pay my people, they gonna go elsewhere or leave the field. And as you already know, we have the greatest education in the world in Iowa, but our quality providers are constantly leaving the field, going to the coast, East Coast, West Coast, and to the South. So we got to try to do something to keep our providers here in Iowa. We're going to constantly lose these great providers in this great state of Iowa. I'm not trying, that's just being honest. So that's what we got to do. What can we do to get better?
Hi, Byron. I'm Mitch Wasden, the plan president for Iowa Total Care. I will circle with our team and we will contact you tomorrow and have an answer to your questions. All right.
All right. And if we need to drop names, I've been having the biggest problems with Jody Manning and all of that. I've been waiting on a phone call from Jody since May. And I ain't heard from her yet. And I can send you all the emails. I got a paper trail and all of this and everything.
Yeah. No, I
can send that
believe
to you.
you.
There's some serious problems.
Yeah. Okay. We'll circle with our team and get right back to you.
All righty.
Thanks.
Thanks, Byron. We'll make sure everyone gets back to you. Also, I do see your comment about oral health and mental health being tied together. I think oral health is one of those areas where it is underrepresented in how we talk about healthcare, and definitely a part of whole person health. So totally agree with you. There was a previous comment from Leah Kroger about whether or not we're concerned about the decreasing number of Medicaid enrolled dentists accepting new patients and how it will impact the oral and overall health of Iowans. You know, we're always concerned if we see any type of decline in access to providers. So definitely something that we're keeping an eye on. Unfortunately, there are some things that are out of our control in that space, but Heather and Katie have been working really hard with Delta and MCNA to ensure that we have some adequate network adequacy across the state, and also on trying to think about some creative ways that we might be able to bolster that access with maybe some incentives. So more to come on that. We are getting close on time. We have a number of questions still in the queue, so we will address all of those, post those. We'll reach out to everyone who sent something in. A reminder again, Kevin, are we going to put our website or our new email address up on the website?
Yes, and we'll also a reminder that we post the recording of this meeting too on the website for those who had to drop off early or couldn't make it.
So a couple of things I would like you to think about and shoot into the email box. If there are specific areas where you would really like to participate in a process improvement, business process improvement, health outcome improvement work group with Medicaid, shoot your ideas over to that email box. We will be recruiting actively for our provider outcomes one pretty shortly after the provider survey results get calculated. So that will be the first one, but that will be one of many that will be kicking off here soon. Really appreciate your time. If you have any other questions that you didn't get into this particular chat during the town hall, again, that email address, the IME Town Hall email address is available for you to send additional questions, concerns, and comments. So thank you so much for all you do. Mitch, Jeff, thank you for coming today. IME staff, thank you for coming. Medicaid providers, really appreciate all of the work that you do. We're all in this together. We're all on the same team. So let's just keep moving towards the goal. Have a great weekend. Bye.